Welcome to episode 7 of Triangle Dentistry Talk. I'm here today with Dr. Justin Valentine with Tar Heel Periodontics. I'm your host, Dr. Carl Bernstein with Bernstein Orthodontics. How are you today, Justin?
I'm doing great, Carl. Thanks for inviting me.
Welcome. We got Justin here today on a little hour break between work and patients, so we're thankful to have him here and for him to give us some opportunity to talk about periodontics and the office that he's with at Tar Heel Periodontics. So just tell us a little bit about yourself, introduce yourself to everyone.
Yeah, sure. So I was born in Danville, Virginia, about an hour north of Raleigh and Durham. And as a kid, I've always been interested in science. It was my favorite subject in school, and had a great relationship with my dentist, and that made me want to pursue dentistry. He convinced me that dentistry was a great profession, and I always enjoyed working with him. And in undergrad, I majored in clinical laboratory sciences, and from there, attended UNC Chapel Hill, and actually worked as a general dentist for a few years after graduating. I wasn't quite sure which area of specialty I was interested in, but after working for a few years, I realized that my passion was periodontics. And so, for those of you who don't know, periodontology is dealing with the structures that surround teeth. So perio means around and dental means tooth. So we actually deal with structures that surround the teeth, which would include the gingiva or gum and the bone. And we do surgery on those areas. And I've been working in perio ever since 2016, and it's been a blast. The profession has changed quite a bit. And Carl, I hope we get a chance to talk a little bit about the history of perio and kind of where it's headed and where it began and kind of where the future is going to be in this profession. It's a very interesting and very fascinating.
Yeah, I think periodontics always seems to be one field that a lot of people may not have a full grasp on, but everyone knows of gum grafts, and people like to think and say that they may hurt, but we'll get there. We'll talk about how we maintain patient comfort or discomfort, and we'll get to that later on in the podcast. But tell us about where do you work? What office do you work at here in the Triangle area?
Sure. So I joined the practice Tar Heel Periodontics and implant dentistry in 2016. And when I first joined, I started working in the Durham community, and that's where I primarily work today. We have, as you guys may know, 6 locations spread throughout the Triangle. We're growing and expanding. We cover the regions of Durham, Raleigh, Cary, Wake Forest, Pittsburgh, and the did I miss one, Carl? I think we got them all.
Is Holly Springs one? Are you guys
Holly Springs, we have Pittsburgh is kind of close to that area, so
okay?
we haven't gone there yet. So I work primarily in our Durham, Raleigh, and Cary locations, and I've gotten to know the community very well. They've gotten to know me very well, and so it's been a blast. We do continuing education in the community to get to know the docs better, and the docs get to know us better as well.
Yeah, if you guys are hockey fans, I think Tar Heel Periodontics is pretty big in the hockey community, isn't it? With Carolina, is it the Hurricanes? I'm not a huge hockey fan, a huge
Yeah,
hockey watcher. If you're noticing,
Yeah, so we actually had a partnership with them years back. I would say for about 5 years, and it's been a blast. Working with the Hurricanes was very fun. We would attend many of their games, and get to meet some of the athletes. That was a blast, a lot of fun. We
I
currently
like
work
to
with it.
always I like to always joke around, that it's such a great partnership because hockey players lose teeth.
Yeah, it's very
They're
interesting.
always getting hit in the face with something.
That is correct. A lot of them missing their front teeth, but they wait until they retire to get that
Yes.
fixed for good reasons. Number one, it kind of makes them look tough. You're missing your front tooth, you're kind of legitimate in that way. But then when you finish, you get the implant, you get it restored. Otherwise, the risk is you'll knock the implant out, and if that happens, it's actually a really big problem. But yeah, that's a very common injury in hockey, and being a periodontist, we get a chance to help them.
Yeah, so that's wonderful. And let's kind of jump into a little bit about periodontics. So, to most of our audience, I think people have heard of it, and understand the word and have seen it and heard of gum grafts as kind of probably the common and implants. But tell us a little bit about periodontics, and then we'll keep going down the list and try to get as much information to our listeners.
Sure. So periodontics, as we were saying earlier, deals with the structures around teeth. And so if we think about what those structures are, we have the tooth itself, we have the bone, we have the gum tissue, and we have the ligament. So periodontal disease is one of the main things that we treat as periodontists. And so periodontal disease is called periodontitis. And periodontitis means bone loss and inflammation around teeth. It's caused by bacteria that leads to an infection that leads to the loss of the attachment being the bone, the ligament, and the gum tissue. And so what's really important is that if periodontal disease goes untreated, patients lose their teeth. And the earlier we treat and intervene, the more likely the patients are to keep their teeth. And that's a big deal. We see in our community lots and lots of patients who have periodontal disease. The prevalence of periodontitis is almost 50% in the United States population. And so
So let
people
me
who
ask
go,
you,
yes,
sorry for interrupting, but let me ask you, so what is the cause of gum disease or
yeah,
periodontitis?
yeah. So there are two main factors involved with periodontal disease, the bacteria and also the host response, we call it. It's a genetic component to this disease. If you were to take 100 people from the population and you were to sample their mouths, you would find a large majority of them are healthy. You would find 10% of them are extremely unhealthy. You would find that another 10% are doing pretty good. And then you find some that are right in the middle where they have mild periodontal disease. And so periodontal disease, again, is caused by the bacteria. And then some of these individuals who are on the opposite end of the bell curve, they have a genetic predisposition to having a very severe reaction to that bacteria, the same bacteria that we all have. And other people have an excellent immune system and they can have tons and tons of bacteria and very little response, and they actually look quite healthy. So we're actually battling two things when we're treating this disease. We're battling the genetics and we're battling the bacteria. And we have different ways to approach the treatment for those individuals.
Now, how would you say, with what you're saying, there's some genetic component and some people may feel like they're in an unfair position to other people, but how do people at home prevent getting periodontitis and gum disease?
Great. And that's where you come in, Carl. So keeping up with your general dental appointments is very important. We call it periodontal maintenance. So for people who have periodontal disease, they need treatment. And so the treatment, if we catch it early enough, we can treat it very conservatively with simply a deep cleaning, also known as scaling and root planing. And that is a very conservative procedure. It's non-surgical. It's typically accomplished in 1 or 2 visits. And in people who have mild disease and who don't have the severe genetic component, they actually have a pretty good response, very predictable response. And then those patients go in something we call periodontal maintenance, which means having regular cleanings done on a regular basis. The Academy of Periodontology recommends every 3 months. And if they do that, research shows that those patients actually lose fewer teeth over the course of a lifetime compared to someone who doesn't do periodontal maintenance. There's tons of literature that supports this, including patients who have dental implants. If patients skip out or miss their periodontal maintenance visits, they actually tend to get implantitis, which is a similar process to periodontitis. So it's extremely important to maintain the health of your teeth and your implants and your overall systemic health. We'll get a chance to talk later, Carl. I would imagine you have some questions
Mhm.
about the oral systemic link as well. And there's a medical component, a systemic component to this as well when it comes to periodontal disease and treatment and outcomes.
Yeah, so we definitely will get to that and in the near term. Now, one question before we go a little bit more into some of possible treatments, what for people listening, what are all the treatments that can be done at Tar Heel Periodontics and by periodontist?
Good question. And so periodontics encompasses the full scope of dentoalveolar surgery. And so that includes hard and soft tissue procedures. So let's talk a little bit about the hard tissue procedures. By hard tissue, we mean procedures that affect the bone. So that would include extractions, both non-surgical and surgical, the placement of bone grafting materials around teeth, or in an extraction socket or in a edentulous site to rebuild lost bone. And the primary purpose of rebuilding bone is to be able to place a dental implant in the future. It includes hard tissue biopsies, includes alveoloplasty, alveolectomy, so reshaping the jawbone, removal of tori or large bone parts that allow for dentures to fit, for instance, or if it's uncomfortable to a patient. So those are our primary hard tissue procedures. Our soft tissue procedures would include, obviously, soft tissue grafting, which is a very common problem for patients in the general population. Upwards of 90% of patients actually have recession in their mouths. And many of those patients may require soft tissue grafting to prevent that from getting worse. But other soft tissue procedures would include soft tissue biopsies, frenectomies, which is the removal of dense connective tissue attachments that can cause and pull on the gum tissue and lead to recession. So we call those frenectomies, or tongue ties. We can remove tongue ties with a lingual frenectomy. And we do some aesthetic procedures as well. One of our primary aesthetic procedures is called crown lengthening surgery. So for patients who, for instance, we see this commonly in teenagers who have orthodontics, and after their ortho is complete, the gum tissue reacts to the braces and they get what's called gingival hyperplasia, or enlarged gum tissue. It looks very unaesthetic. It's hard to clean. They collect a lot of plaque. Actually saw a patient like this yesterday. And we can actually redesign and remove that excessive gum tissue and reestablish the normal anatomical proportions of their gums and their teeth. And that allows these patients to have a confident smile. These patients, they have prom coming up. They have big events coming up in their life. They're young. Confidence is important to them. And we can actually give them back their confidence that they may have lost. Not only for kids, but also adults. Many adults also have this problem. Certain medications can lead to gingival hyperplasia as well. Certain blood pressure medications can lead to it. We very commonly see that in patients who have amlodipine or calcium channel blockers. So for adults, we can help them with this procedure as well. And that pretty much sums up the soft tissue procedures. We also do sinus elevation procedures for helping with dental implants, both the osteotome and the lateral window sinus lift procedure. So to summarize, essentially the full scope of dental alveolar surgery, both hard and soft tissue.
That's great. And one thing, we were kind of talking about, and patients may ask, what can I do at home to hopefully prevent getting periodontitis? Or even if I did have it and had some treatment and now I'm in a, controlled state and my gums and hard tissue are healthy, what can I do at home to maintain that?
Very good question. So as we talked about earlier, we know there's a genetic component to periodontitis. So one of the things that you can do, if you know that your mother or your father or your grandmother had or has periodontitis, let's say your grandmother has dentures or your mother has a partial denture, then you're probably at high risk. And so one of the things you should do is look at your family history. If you know your family has it, you should probably see at least your general dentist. Go see Dr. Bernstein or have them do an exam for you, and they can do some radiographs and see if you have some bone loss on your teeth. The earlier you catch it again, the better. And so, so check your family history. If you know you have periodontal disease, things that you can do to help control that disease is very good oral hygiene. And that's actually one of the most important factors and parameters in controlling periodontal disease is oral hygiene. Electric toothbrushes work really well. Research shows that it removes more plaque, it's more effective, and patients actually have better control of their disease if they use an electronic toothbrush versus a manual toothbrush. Also, there are certain adjunctive aids that can help. Water pick we would consider adjunctive for people who have large spaces between their teeth. It can help remove more of the plaque and bacteria. Also, interproximal brushes help. They do a very good job of removing plaque if you have wide spaces, again, between your teeth due to periodontal disease and gum tissue recession. And then flossing, very important. Make sure every night before bed to floss. Brushing twice a day for 2 minutes. Those are your standard and very typical ways of controlling it. And then again, some adjuncts can be water pick, water flosser, and interproximal brushes. And obviously make sure you follow up with your 6-month or 3-month cleanings with your general dentist.
Let's talk about, what is the most common procedure that you see at your office at Tar Heel Periodontics? And then we can kind of go into a little bit of information, and kind of the common questions people ask, of how much does the procedure hurt? Is it
Mhm,
uncomfortable? What's healing time? Things like that, because those are
mhm.
definitely things that patients are definitely wanting to figure out.
Sure, absolutely. The most common procedure in our practice and most practices in periodontology would be scaling and root planning. Because it's the most common disease affecting the United States population other than dental caries. Interesting fact, dental caries, which is what Carl treats, is actually the most common chronic disease in the world. And then right behind that would be periodontal disease, which again affects about half of the population. And so the most common procedure in our practice would be both non-surgical and surgical treatment for periodontal disease, which would include the initial treatment called scaling and root planning, followed by reevaluation, followed by, if a patient needs it, osseous surgery. And we determine the need of osseous surgery on a patient by patient, case by case basis. A lot of different variables depend on whether or not they need that procedure, but that's a procedure that can get us better control of the periodontal disease. Interestingly, one of the things that we've developed in our specialty over the past few years has been something called periodontal regeneration. We can actually use growth factors and proteins to stimulate the body to form new bone and new attachment around their teeth. And so when periodontics first started as a profession, this was unavailable to us. And so people had very limited options for keeping their teeth. It was pull the teeth and do dentures or keep teeth in a very compromised state. And so periodontics would try its
Hmm.
very best to keep teeth and without growth factors that was challenging. We would only have traditional surgery available to us, which is good, but it's resective in nature, meaning we have to reduce and remove and reshape some of the bone, and the bone is what attaches the tooth to the jaw. And so we want to preserve as much of that as possible. With growth factors, we can actually regenerate that bone. And that allows for us to, instead of treating periodontal disease resectively, we can actually rebuild it and regenerate it. So that's been very fun and a very good thing to have in our profession. And that's true around dental implants as well. Implants can lose bone. We can actually regenerate some of the bone around the implant. Um, but as time has progressed, we have seen newer treatment modalities available to us. And dental implants is one of those. And that's the other most common procedure that we do in our practice is dental implants. Dental implants, they are the replacement for teeth. The most common reason to lose a tooth is typically due to periodontal disease. And so for these patients, we can actually replace their missing teeth now by using dental implants, which are titanium fixtures, little small titanium pins that we place in the jawbone. When we place those pins, the body will accept that as biocompatible and bone will actually grow around the implant. The implant will become stable, and then one can attach teeth to those implants, whether it be a full set of teeth or an individual tooth or a few teeth called a bridge. And so that has changed our profession, not
Hmm.
only periodontics, but literally it has affected every single aspect of dentistry over the past 30 years. And so that would be probably our second most common procedure. And then the soft tissue procedures that we discussed earlier, the grafting procedures, the aesthetic procedures, really allows for us to transform patients' lives and give them something that they can feel confident with, that they can function with, they can eat with, and have something that's very predictable and long lasting.
So one big question, let's say when it comes to implants, we always hear patients ask is how, let's see, once I get an implant, how quick are they or how soon are they able to get a tooth or a crown or bridge on top of that? Because some of that has to do with how it heals and how the bone gets around that implant. But how quick would they be able to get a tooth on top of their implant?
Yeah, good question. It varies. In some instances, they can get a tooth the same day. In other instances, it can take as long as 9 months. It depends on the situation. So let me give you an example. Some patients, if they have very dense bone and they have a very good bite. In other words, when their teeth come together, there are no discrepancies. Sometimes those patients can get a tooth the same day. We would actually
Mhm.
place the implant, take an impression of the implant, send it to a lab. They can mill a crown, or sometimes dentists have machines in their offices that can mill a crown right away and then put that onto the implant, and they're done. Or sometimes we'll do a temporary crown. We will place the implant, refer it back to the general dentist. They'll make a temporary crown chair side that same day, and patients actually leave with a tooth. And so that's actually not too uncommon. We do that quite frequently for our patients, but these patients require pristine bone, has to be very healthy, no periodontal disease, and a good bite. Those are the criteria. Then there are other cases that can take almost up to a year, and those are patients who require significant bone grafting. And so, for instance, if we have to do a lateral window sinus bone graft for a patient, we would wait typically about 6 months for that graft to heal. Then we would place the implant, wait another 3 months, so that could be up to 9 months for those patients.
Now,
But on average, oh, go ahead.
would you see any difference when it comes to that, the healing, or when it comes to the immediacy of being able to place a crown on it based on age? So is a younger person better than an older person, or is it really more just important with the health of the bone?
Mhm.
If there was a previous infection in that area, is that more important?
Good question. I want to back up for 1 second.
Yes, go
On
ahead.
average, at about 3 months, patients can have their crown. So about 95% of patients will be ready for their crown at 3 months from implant placement. And then again, we have the other extremes where they can have it right away or up to 9 months. In terms of the healing of an implant, the research shows that age is actually not a factor, not a significant one. It's more so the health of the patient. For instance, if we had a healthy 90-year-old patient, takes no medications, not a smoker, not a diabetic, versus a 40-year-old smoker, type 2 diabetic with an A1C of 10, the 90-year-old would probably do better than a 40-year-old. And so what's really important is the health of the patient.
That's great. And that's, I think, always people wonder, am I too old to get this treatment? And I always tell everyone, you're never too old. If you want it, go ahead and do it, because you probably still got a lot of time left. So never look at the end, just keep going on the journey. So I'm thankful for that answer. And that's what, we always tell everyone as well. So I think one thing that we always hear about is gum grafts. With periodontics, and people always say that this can be the most painful procedure in dentistry. It hurts so much. But honestly, I've been hearing, most patients coming back, especially our Tar Heel periodontic patients, and they say it wasn't too bad. Obviously they're really good at managing care, very good at managing patient discomfort. But if you could explain to people, I think the big questions with gum grafts that I hear is, does it hurt? Obviously, that's number one. But two is, how long does it take to heal? And when can I just get back to my normal life and not have to worry about the healing of that gum that was placed?
Yeah, great question. Now we hear it literally every single day because we're almost doing grafts every single day. Again, as we talked about earlier, it's a common problem in the society. About 90% of patients have recession in their mouths, and so in the old days of grafting, we used to harvest the tissue from the palate, and we would take it full thickness, which means we would cut out a large piece, and it would go close to the bone, and then we would just let that heal on its own. And that can be very painful. And so, over the years, we have modified our techniques as a profession to be able to harvest the graft more comfortably for patients, which allows for faster and better healing. And so, what we do is oftentimes we use tissue called tuberosity tissue, which is tissue that comes from behind their last molar. That's a great site because the vascularity there is different. We don't see the same number of nerve fibers there. There's less fatty tissue there. So the tissue quality is better, but it's also much less painful harvesting in that area because of the less nerve fibers that are associated with that region of the mouth. The tissue repopulates more quickly. And in fact, I would say probably for the vast majority of patients I'd harvest tissue from in that region, the next day they don't even notice it. And so that's the beauty of using tuberosity tissue. If for some instance we can't use tuberosity tissue, we can do a traditional harvest from the palate. And when we do that, we'll typically cover the site with a collagen membrane, and that's fully dissolvable. And we'll use a combination of dissolvable sutures and dissolvable surgical gel, which that gel will actually coat the membrane. And that essentially is creating a new layer of skin that will just automatically dissolve away on its own. And when it does so, by the time it goes away, the new gum tissue or the new skin tissue will form underneath it. And so that makes the healing much, much better. Go ahead, Carl. What other questions did you have about grafting? I kind of missed the last few
Yeah,
things
no
you
worries.
had.
Yeah, so I guess the big one would be how long is the recovery time
Hmm.
for a gum graft?
Sure. So recovery time for soft tissue grafting is typically 3 weeks in terms of the integration. I always tell my patients what you can expect is for the first 3 days there to be some mild to moderate discomfort, including swelling. Swelling is probably the most common thing we see with gum grafting. That will typically last again from 3 to 4 days. And things that we do to help control swelling would include a steroid pack. Oftentimes, we'll start that medication a day or two before surgery, and that significantly minimizes the swelling because actually most of the discomfort comes from the swelling. It comes from the swelling and the inflammation. So if we can get ahead of that with that medication, that significantly improves the healing rate and how they do with the procedure. And so after the first 3 to 4 days, it starts to feel back to normal. And then we ask patients to do a soft diet for that first 2 weeks, chewing on the opposite side from where the graft was placed. And essentially just being gentle and delicate in the area. The graft will heal on its own. And by the time we see patients at 3 weeks, it's fully healed over. The soft tissue fibers reinsert at 2 weeks. They form a new connection to the bone. The tissue will integrate at 2 weeks. The tissue will become thicker and stronger. And we'll see patients at the third week to verify that healing is complete. And the vast majority of them are healed over at 3 weeks. There are some cases where it could take longer. Those are typically smokers and diabetics or patients who are not healthy. They may heal a little bit slower. So in those patients, it could take sometimes 6 weeks for the recovery to be fully established. Then that doesn't mean they're going to be in pain for 6 weeks. It just
Right.
means that we're waiting for the graft to fully integrate. Pain is subjective, of course, and it depends on the individual. Typically, patients who have a higher level of anxiety tend to have a higher level of pain. They tend to have more pain and longer pain and discomfort than patients who don't have that level of anxiety. What I like to do for my patients, I give them a dental anxiety questionnaire to fill out before at their initial appointment. And I can actually use that. It's an evidence-based questionnaire. It's a series of 4 questions. It's very accurate. And that gives me a gauge for what their level of anxiety will be. And if I know that in advance, that can help me for the surgery. I can prescribe certain medications to reduce anxiety. I can prescribe certain medications to help reduce pain. And those patients tend to do better. And so that's really helped our practice a lot.
Oh, that's great to hear. And, many times managing pain happens even before the procedure. So I think, if you guys are listening, Justin does a wonderful job with that, and Tar Heel Periodontics has that perfectly under control. So that's why they have so many offices. They're trusted around the community, and obviously they've treated a lot of people, and that continues to in the future. One thing that I had, a question on, with orthodontics, obviously we see, a lot of orthodontic patients, and the concern would be with gum grafts, if they have recession, does that need to be corrected prior to orthodontics? I guess sometimes dependent on severity, or should that be corrected after treatment? Or if they're already in treatment with braces and they're starting to get some recession, should that be completed after braces come off, or should that be completed in the middle of treatment? Is there a right or wrong or better answer? Or it depends, like everything in dentistry.
Great question. We get this a lot. So first of all, patients who receive orthodontics, it's not uncommon for them when they're done with orthodontics to have recession develop. And that's because as teeth are being moved in the jawbone, if they're being moved towards that jawbone, it can actually thin out the bone, which will thin out the soft tissue, which can lead to recession. And so patients who have risk factors for recession, which would include thin tissue, high frenum, or lack of keratinized tissue, those are the patients who should at least get a periodontal consult before orthodontics. Now, at that consult, we may say this patient actually has recession, but they have a very thick band of keratinized tissue, greater than 2 millimeters. The tissue is thick. They have no periodontal disease. And we may say, actually finish ortho first. Or we may have another situation where a patient has a high frenum. They have less than 2 millimeters of keratinized tissue. Maybe they have a history of periodontal disease. We may say, you know what, let's graft this before we do ortho because the risk is very high. If they move those teeth, it could actually generate a significant amount of recession. And so we can get ahead of the recession and get the tissue thicker. Then when they finish ortho, they may have very little, if any at all, recession by the time they're done. Now, if they're already in ortho, no problem. If the recession develops halfway through treatment, I would simply ask the orthodontist to keep them in the same tray if they're doing Invisalign, not to advance to the next level, or just keep them in the same arch wire. And then we'll get the graft done with the wires on, with the braces on, let that stabilize, take about 6 weeks for full stability, and then go ahead and resume the orthodontics after that. So we can actually intervene at any time, whether it be before, during, or after. But the recommendation or the preference would be to actually at least get a consult before the ortho if there are risk factors involved. And then we would make our decision based on what we discussed.
Well, that's good to hear. It's always a common question that we hear, and obviously people are concerned of that and don't want to have recession. So it's good to know what to be able to tell people from an expert. One thing that we talked about in the past, earlier in this podcast, was about health of periodontitis and how it affects your whole body health and your systemic health. And I'd love to go in a little bit more detail of why, as dentists, and especially you as a periodontist, why we are concerned about that health and why we want patients to hopefully become aware of that and hopefully manage that health, because it does have more than just effect on our mouth. It does affect our general health, our systemic health. But I know you know a lot more on this, so please, go into some more detail for people to understand.
Yeah, absolutely. There is a link between medicine and dentistry. It's amazing to me how long and how we still continue to separate the two from each other. I actually had someone talk to me about this a few days ago. They asked me, "Hey, Justin, why is it that medical doesn't pay for dental? Like, why are they so different? Like, what is it about the mouth?" And I'm like, the mouth is a part of the human body, and so they're related. And so, for instance, we have seen tons and tons of research coming out of the periodontal literature that links periodontal disease with overall systemic disease. Some of the more fundamental studies look at inflammation. Inflammation affects everything in the human body. It essentially makes any and every disease worse. Every disease is affected by inflammation, whether it be COVID, whether it be diabetes, whether it be heart disease, any disease you name it, cancer in particular, is affected by inflammation. And so a lot of our patients, particularly in perio, who the average age is around 40 to 60, they have some type of comorbidity, whether it be hypertension, cardiac, etc. And so it's very important they maintain health of their oral cavity. Studies have looked at people with periodontal disease and doing blood draws and looking at C-reactive protein, which is a marker of inflammation. And they actually have shown and proven that if one has oral inflammation, C-reactive protein increases, which is a systemic marker of inflammation. So what that means is that if your gums are not healthy, your body is not healthy, and your body is being impacted by that. We have seen the reverse. We have seen people who get treatment for periodontal disease have less C-reactive protein. And so in other words, if you get treatment, your inflammation goes down, not only in your mouth, but also in your body. And we have seen people's diabetes scores, their A1C levels improve. We have seen people's hypertension improve. And we have seen, for instance, my research when I was in dental school was the link between inflammation of the mouth and HIV disease. We have actually seen people who have HIV and they get periodontal disease treatment. We've seen their viral levels improve. We've seen their CD4 counts improve. So it affects any and every disease that you can think of. And so it's extremely important to control oral inflammation. And I think that our medical colleagues are understanding this better and better.
Hmm.
I'm hearing it more from my medical colleagues about the importance of having a dental exam and a dental checkup. But again, this disease affects 90% of the population. And so a lot of these people have it. And if you think about individuals getting treatment for medical problems and they're having a problem controlling their sugar or they're having a problem controlling the cancer, try doing a dental exam. Let's check them
Hmm.
out. A lot of these patients have periodontal disease. A lot of them have severe disease, and it's startling. And once we get that disease out of their body, out of their mouth, they actually tend to improve. They feel better, and systemically, they do a lot better. So it's something that I think is vastly underlooked at by our medical colleagues.
Hmm.
And I think that we need to continue to get the word out through literature, through journals, through podcasts. I think we need to continue to get the word out on that.
And I think exactly what you said is a lot of people almost immediately they feel a difference. And I think a lot of definitely medical providers are starting to become more aware of oral health and how it affects the body and how it even affects sometimes the outcomes of their surgeries that maybe 30 20, 30 years ago they didn't even think that the mouth could affect, a healing site on the bottom of your body, or on your legs.
Mm-hmm.
And it can, everything is connected. Everything, if the mouth is known to have a lot of bacteria, but the positive is healthy bacteria. We don't
Mm-hmm.
want it to be bad bacteria that's going to cause more issues for the rest of us. And I think that's the positive. And I think dentistry has really improved in getting that awareness out. And I think that's the biggest thing, like you said, is getting that information to people to really enact that change and to really improve our oral health. Because these dental appointments, though no one really enjoys going to the dentist, we know it is one of the bigger fears in in definitely most people's lives. But it's these appointments, as you go to one appointment, you find out, you know what, it's not that bad anymore. It's actually pretty comforting. The offices are really nice, they're welcoming, everyone's having a good time. And also the appointments aren't as painful as I think people maybe remember from 20 or 40 years ago, or
Yeah.
people who are elderly. And I remember my stepdad saying, he's like, I remember having dental work done without even numbing, and I don't remember that being a thing. And I said, now he goes to the dentist, he's like, it's not nearly as bad as it was. So I think it's getting that information and that awareness out.
Yeah, and we're using sedation as well in dentistry, and that has really helped people be able to get the treatment that they couldn't get otherwise. And so, in our practice, for instance, we do various forms of sedation, be it nitrous oxide or oral sedation or intravenous sedation. Depending on what these patients need, we're able to meet their needs. And one of the things that helps is the anxiety score that we talked about earlier that allows for me to determine what type of sedation is appropriate for that patient. And that makes it comfortable for them to get these procedures done.
So we talked about, a little bit about periodontology. We talked about, what you guys do now, but what about what should we expect in the future from periodontics and
Mhm.
periodontology, and what is the innovation and the new thing that we are going to be seeing in the next few years, or even the very far long term? But what are those?
Yeah, good question. So we're always looking, historically in dentistry and even currently, we treat most diseases resectively. Yeah, even in operative dentistry. If you have a cavity, your dentist will use a drill to remove tooth structure, to remove the cavitated portion, the bacteria, and then even some of the healthy tooth structure gets removed as a process of that, and a filling gets placed on the tooth. Well, then that tooth gets more decay and now it needs a crown. And so more tooth structures removed. Then eventually the pulp gets involved. So now the pulp tissue has to be removed. And then eventually the tooth fractures and now the tooth has to be removed. And so everything is kind of treated in a resective approach in dentistry. And in perio historically has been a resective approach as well. We remove some bone tissue, we reshape and recontour the bone. That's resective. We remove diseased portions of the gum tissue, we cut that back and then suture it. That's a resective procedure. As I alluded to earlier, we're trying to now use regenerative procedures, growth factors, and proteins. And I think that a lot of research still is looking at that. In fact, laser research is something that is relatively new in periodontics and has gotten a ton of research over the past 5 years in support of it. And so, what lasers can do is a very relatively non-invasive procedure, and the energy from the laser can actually reactivate some of the growth factors, some of the genes that stimulate growth, and actually allow for regeneration of bone around teeth by simply using the energy from a laser light. That energy also can target, kill certain bacteria. If we add dyes, certain chemicals inside the periodontal pocket, the pathogenic bacteria can actually take in that dye, and then the laser wavelength can be targeted to absorb the energy in that dye. And so we can actually get targeted killing of pathogenic bacteria using lasers. So lasers are very interesting, not only in general dentistry, but also in perio, and can allow for some of the regeneration of these attachment structures around teeth in a very conservative fashion. So I think the field of perio is evolving to look more into a regenerative approach. We're also looking more at a host modulation approach, where instead of targeting strictly the bacteria and resecting, let's target the person. Let's target what's going on with their bodies. For instance, patients have a protein called matrix metalloproteinase. That is a protein that actually eats away at collagen, which is the protein that we find in connective tissue and bone. And so they're eating away at the structures that make up the bone and gum around teeth because they're trying to fight the bacteria around the teeth. Well, we can actually use certain medications that target matrix metalloproteinases and actually downregulate the host response. For instance, some patients might be what we call hyper-responders. If you put certain bacteria in their mouths, their immune system actually ramps up quite a bit, and it actually leads to a lot of collateral damage. So we can actually use medications that can actually downregulate that immune system and not affect other parts of the body. One of those medications is called Periostat. It is a low-dose tetracycline medication. And what it does is it actually downregulates MMP activity. And patients who take this medication can actually have better control of their periodontal disease. So the combination of host modulation, periodontal regeneration, these concepts are evolving in our profession and allowing us to be more conservative and actually regrow these lost attachments around teeth. So we can now save teeth, as always been our goal, instead of replacing them. But if we have to, we can replace them with implants, which we didn't have available to us early in this specialty. Some really cool things too that we're looking at is 3D scaffolds. So we can actually scan a patient. We can actually make a 3D model of their jaw. We can actually make a scaffold that is exact replica of the periodontal defect and actually put bone and proteins within that scaffold, put that next to their jaw, and then suture that in place and actually very, very effectively regenerate lost bone that way. So that's some really cool technology that's available. And we are using that in our profession. It's not widespread yet, but it is available for severe cases, let's say an automobile accident or something like that. So yeah, it's very exciting. That's why I like perio so much. We have the opportunity to regenerate what the body has lost, and it's pretty cool.
Yeah, I mean, I think the innovation that's here and the innovation that we don't even know about yet that's going to come in the future is pretty amazing. We're kind of at a lucky time in the career that so much is changing technologically that some of the things that we think aren't possible will be possible at some point. So I think that's exciting to hear and exciting for patients in the future as well.
Mm-hmm.
Is there anything else that we'll do one fun thing in a second. It's called wrong answers only. It's just a fun way to end it. But is there anything else you'd like to tell people or let the audience know before we get to the end?
I think that since we're talking about periodontics, we talked earlier about how do you know if you have periodontal disease? What should you do? This disease, again, affects about half the population, and so if you're listening to this podcast, there's a chance that you know someone who has periodontal disease. There may be someone in your family who has it, and so, if you don't go to your dentist regularly, uh, ask your dentist about periodontal disease. Make sure you have them take some X-rays, look at your X-rays, and let you know if you're at risk. If you know you're a diabetic, you're at high risk. If you're a diabetic, you're at high risk for periodontal disease. That's one of the risk factors for periodontal disease. If you're a smoker, you're at high risk for periodontal disease. So you should make sure you see your dentist, have them do a periodontal screening on you, and if you need to, they'll determine if you need to see a periodontist. And so I think that those are important things for our patients to know. There is a link between the oral cavity and the health of your mouth with the health of your body. And get that word out, and make sure you've had your dental exam and your dental visit, and go every 6 months if you're healthy. And if you have a history of periodontal disease, every 3 months.
Perfect. Well, I think hopefully everyone listening understands a little bit more about periodontics, understands a little bit more about Tar Heel Perio, and also understands a little bit more about Dr. Justin Valentine and his passion for the career and his passion for periodontics, but also that's what makes him such a great periodontist and a great dentist, because he is passionate, he cares, and he's always following up and learning. Even when we could stop learning, he's on the top of the curve and learning the new innovative techniques for the field. So we thank you for being part of the Triangle community and helping all the patients here and making them comfortable and treating their issues and disease. And if you don't have anything else to say from here, we can do a little fun send off. It's called Wrong Answers Only. Essentially, what this is it's just 10 questions, very basic ones. And all you have to do is try to answer as quick as possible, but always the wrong answer. So, yes, answer whatever you think. So, we'll start off easy. What's your name?
Jackson,
How old are you?
19,
What country were you born in?
Canada,
How many stars are on the US flag?
32,
What type of car do you own?
Honda,
Name a fruit.
jackfruit.
Still a fruit, isn't it? Where do you work?
Tar Heel Periodontics. Oh wait, no, I had to say the wrong answer. Where do I work? Let's see. AutoZone.
Name your favorite coworker.
Scottie Pippen.
What is your favorite dental procedure?
Root canals.
Finish this quote. Life is like a box of
Candy.
and that's it. We just have some fun just to end it, end the podcast with some laughs. But we really greatly appreciate you coming on, giving us your expertise, explaining a little bit more about Tar Heel Periodontics, explaining a little bit, informing us about you, who you are, what you like to do, and why you make our area and our community so much better, and improving the health of our citizens and really the Triangle area. So we greatly appreciate it, and it's always fun talking with you, Justin.
Awesome. Thanks a lot, Carl. I appreciate that.
No problem, and have a good rest of your day.
You too. Take care.